Case 2. 62-year-old female with medical history of diverticulitis, tinnitus, asthma, who presented with sore throat, cough, and dyspnea on exertion. Patient was never a smoker. Family history showed gastric cancer, particularly in grandmother. And on CT scan was found to have left lower lobe 2 centimeter nodule near the hilum of the common basal segment of left lower lobe. And again, PET scan was done, which showed that there was a high SUV at the lung lesion and there was no hilar lymphadenopathy. You can see over here the lung cancer. Before we move into what happened, I want to highlight something over here as well as a side note. And that is that more and more cases we are seeing now in our real world practices for lung cancer who never had smoking history in the past. And very often we have this discussion with the patients when they ask that, I've never smoked, and how can we have cancer or particularly lung cancer? I just want to highlight that various studies, including one of ours, have shown that depending sometimes on the age group, younger age or elderly age, depending on male or female, around 40% of sometimes cases, especially in females and in younger females as well, could be happening in patients who have no smoking history. That's why if you develop any symptoms, and even if you're non-smokers, or even if someone in your family who are non-smoker, if they develop any symptoms, make sure you go and talk with your primary care doctors immediately, who can then refer you to oncologists if there is need arising. Therefore, just wanted to highlight this over here. Do not wait for your symptoms. Always, if you have any symptoms, think about it, reach out to your doctors. Going back to our case again. So in December of 2022, this patient underwent robotic left thoracoscopy, left lower lobectomy, and left upper lobe lingulectomy. As the margins were very close, that's why the lingulectomy, which is on the other portion of the lobe, was taken out as well. The final pathology showed pulmonary adenocarcinoma, poorly differentiated, SNF predominant, with focal mucinous features and minor components of papillary and micropapillary, as well as cribriform growth. These all things are very helpful for a medical oncologist as well as all the decision makers to evaluate the risk factors. And so diagnosis was stage 1A3. It's P-based. P is called because it's post surgery after the resection of the tumor, T1C N0M0. Pulmonary adenocarcinoma of left lower lobe of lung with poor risk characteristics, which one of them is here, STAS positive. And then along with that, patient also had EGFR positive, and I'll show you in the next slide. So this patient underwent Garden 360, which is one of the liquid biopsy platform, and it showed EGFR positive exon 19 deletion. And as you would remember that this patient had stage 1 disease, and still this EGFR gene was present in the blood, which sometimes put the patient into higher risk category, that despite it was a low risk disease burden, we were able to detect this mutation from the blood. There was no PD-L1 expression, and then KRISC next generation sequencing, which was done from the tissue once the biopsy was done and once the cancer was resected, which showed that it was EGFR deletion 19, RB1 TP53, and PD-L1 15% as well. Again, EGFR was present over there as well, just showcasing that this was EGFR positive non-small cell lung cancer, an entity within non-small cell lung cancer. And here is the results, and this is how the results would look like. There was also RB1 TP53 mutations, which can help us in determining sometimes prognostically or give us more idea on how this cancer be progressing or having prognostication too. And as you saw that there were so many characteristics, STAS positive, this liquid biopsy showing positive despite like stage 1 disease, early stage disease. So then there leads to more confusion in a way, or you would like to discuss with your partners, radiation oncologists, surgical oncologists, pathologists, that what to be done. In this case, would you give adjuvant therapy? That was the first question that came to our mind, which means would you give a chemotherapy to a patient who has already surgically resected for early stage disease? There are various meta-analyses which have shown that usually it would be beneficial in stage 1B, whereas this was stage 1A3, right around the cusp. However, this patient had high-risk features like STAS, There was concerns that there could be something on pleural invasion, which means pleura is the covering of the lung, as well as spread to lingula, and then liquid biopsy was positive. So with this high-risk features, there was a common consensus that this patient should receive some adjuvant chemotherapy. Again, this concerns of pleural invasion can be, this was shared by radiologists as well as by the surgeons. So they helped the medical oncologists decide as well that what treatment could be helpful in such setting. And followed by that, there was another trial, ADORA trial, particularly for EGFR positive patients, that osimertinib would be helpful as well. So adjuvant chemotherapy was started. Patient was not able to receive all 4 lines because of toxicities for that patient. However, received at least 3 lines of treatment of carboplatin and pemetrexed. And then osimertinib was started after that as well. Continuing a follow-up for this patient, we kept on doing Garden 360 liquid biopsy to continue checking how the cancer is showing in the circulating tumor DNA. And in the next few slides, I'll walk you through how the results were showing up. We also did CT chest, and it's always helpful every 3 months to evaluate how the cancer is doing. Initially, it showed some mild left pleural effusion. And again, at that time, you're always concerned whether this is cancer coming back or whether this is a new cancer or something else or whether it's a toxicity. And therefore, we continued following the patient. Few months later, in October 2023, there was again CT chest showed that there was large pleural effusion, as you can see over here, which means there was a lot of fluid collected, along with diffuse mild ground glass opacities throughout both lungs, worrisome from inflammatory changes versus pneumonitis. And therefore, osimertinib, which is a tablet, which was held because for concerns of pneumonitis. Steroids were given with tapering. And at the same time, we did Garden 360, the ctDNA test as well, to evaluate if there was any new mutations which were being detected, and it did not show any mutations, as you can see over here. So it continued to show no mutations being detected. Then we entered into monitoring phase for this patient. There was a newer test eventually available with Guardant as well, which is called Guardant Reveal, and it gives more kind of methylation data. Just sharing more information as well, that methylation data can help us evaluate various different solid tumor level or solid tumor alterations which are being shed in the blood as well. And it can be sometimes more sensitive specific, especially when you're monitoring the patient post-surgery as well. That's why Guardant Reveal showed that there was no tumor fraction being detected. We did PET-CT along with that, so radiological scans to evaluate, and it again showed no evidence of disease. As we were also following Garden 360, and at that time there were 2 different platforms which were showing. So we continued doing both the testing, and again, no tumor-related somatic alterations detected. We also saw CT chest, abdomen, pelvis, again stable, no progression of disease. Continuing follow-up, and you can see all the way here till May 2024, and there was no tumor alterations being detected, which means it was showing that the cancer is remaining in remission. And similarly, again in July as well. And just quickly looking at the report again, this helps us very clearly say that there's no alterations. And it also gives us for this particular alteration as well that it was 0.2% initially, not detected, not detected, not detected. So a rationale about why we did this. So EGFR mutations was present from beginning. So it was very helpful to see how this EGFR mutations is showing up in the blood now. There's also, as I mentioned, methylation tumor fraction, which is now available in which was available in Garden Trivial and also different platform now Garden 360 Liquid as well. And both of this correlate really well with radiological tumor. But again, while the literature is showing up, still the standard of care practice is to continue doing radiological scan as well. So, and you can see over here that both of them have really good concordance, but it's still better to do radiological as well as with liquid biopsy, both as well. At the same time, both of this platform, which means the methylation based, which is Guardant Reveal, along with genomic based, which is allele frequency, both of this can be helpful in detecting, and there is concordance between them as well. And that's why we continue doing them. And at the same time, there's methylation. And sometimes, and someone could ask, could we have done just one? At that point, which was in 2022 and 2023, it could not be because the methylation was incorporated in Garden 360 recently in July 2024. So in current time, February 2026 onwards, yes, one of them can be just done, and it can be monitored in future as well, just every 3 months, or depending on patient to patient, every 3 or every 6 months as well. Again, various different studies showing that ctDNA can be used to detect minimal residual disease. So it can help us evaluate if there was cancer ever coming back. And those ctDNA positive cases, and you can see over here, yes, or yes over here, they have early disease coming back and therefore worse outcomes, which has been shown in various studies as well. So more and more data gives us an idea that continuing this detection every 3 months can be helpful and a valuable tool in evaluating how the cancer is doing. This is particularly for another company called Signatera. And for MRD testing, it is currently approved and Medicare covers for following different cancers in following different ways as well. Focusing on lung here, as you can see, for stage 1 to 3 non-small cell lung cancer in the surveillance setting. And at the same time, if the patients receive immune checkpoint inhibitor, can then for those patients as well, it can be used for monitoring of response as well. Continuing and going back to the same case. This patient eventually was found to have brain lesion, advancing her diagnosis to stage 4, required radiation treatment in brain. There was some lag in Garden Reveal, but it showed positive results eventually. There was still no resistant EGFR mutations identified. Um, and as the patient had already received the chemotherapy, as well as patient was already on the tablet, the next step was to determine what next to do, which was amivantamab and lazertinib. There was already some more burden present in brain. Not all of them were available to be treatment. And so shared decision making was done whether systemic treatment would be helpful in such cases. And patient opted to continue and start a different systemic treatment as well. And continuing with this, in August 2025, so a few months before, Garden 360, which we were using for monitoring, showed TP53 mutations, but again, no EGFR alteration. Why I'm highlighting this is because there was new alteration which was being detected, which means that now with different treatment, this cancer is also shredding another genomic mutation, or cancer is shredding the ctDNA, which is also having this another alteration, which is TP53. EGFR is not being detected, but this TP53 is being detected. So what does it mean right now for treatment? What it means right now is that we're not going to change anything, but it just gives us some idea that the cancer is evolving a little bit. And therefore, what I want to highlight over here is that this ctDNA can also help us on identifying clonal evolution of the cancer as well. That when different treatments are given, how is cancer changing its underlying genomic alterations too?